All right, can you guys all see that? Okay. All right, so I'm going to talk to you today a little bit about, like Rachel said, deciphering an EEG, and I'll try to break things down so it can be understandable for a parent of a child who was recently diagnosed with epilepsy and what some of these technological terms mean. And so, just a little about myself. Right now, I am a pediatric neurologist and epileptologist at Rady Children's Hospital in San Diego. I did my epilepsy fellowship up in Orange County at Children's Hospital of Orange County last year. And I did my pediatric neurology residency training at Johns Hopkins back on the East Coast. So I'm very excited to be talking to you guys today about understanding your child's EEG. So first, I just want to say I have no disclosures or conflicts of interest. So first, to give an outline of what I'll be talking to you guys about. So just to break it down, what is an EEG? Why are EEGs ordered? What are the different types of EEGs? How are they performed? Who reads EEGs? And then I'll go through an explanation of some common EEG findings, showing you some examples and giving you a sense of what they mean and how to interpret them. You guys will be EEG experts coming out of this talk, hopefully. And then hopefully at the end, if there's any questions that come up, we'll have some time for questions and answers. So to start, what is an EEG? So the EEG is the short term for electroencephalogram, which basically uses, it's a tool to record the electrical activity in the brain and can detect problems in electrical brainwave activity with how nerve cells communicate to each other. And so through use of electrodes on the scalp, we're able to measure essentially the electricity that the brain cells create and how they communicate with each other, translating signals ultimately into these, what people see as squiggly lines that are then interpreted by the neurologist. So this is sort of, I'm going to break down kind of how it's set up and how we look at it and interpret things so that if you see an EEG, or at least are shown your child's report, you can understand a little bit about where we're coming from when we write these and what things mean. So if you look here, and I hope you can see the cursor. So this is kind of to be an example of a child's head. This is the nose looking forward. And these are where the electrodes are sort of stuck on the scalp with a little bit of sticky tape or glue. And so if you orient yourself where this child is, this side is the left and this side is the right. And it's easy to remember that any number that's odd signifies it's coming from the left side, and the even numbers signify the right. And so the letters, for example, mean frontal, central part of the head, temporal for T, P is parietal, O is occipital, and those correspond to the various areas of the brain. So that's a schematic of a traditional montage, what we say, of where we put electrodes on the child's head. And then this is an example of what the actual readout is. And so an EEG, essentially, each line that we look at represents an electrical potential between 2 points on the scalp. And then when we put them all together, then we can interpret sort of where there are abnormalities and correlate them to where those are in the brain. So for an example, if I were to measure this electricity in this area of the brain, that corresponds, so F7, FP1, it's the left frontal part of the brain, which corresponds to this line on the EEG. So when I will go through some of the abnormalities, if you see them on this line, then you trace it back, and that's kind of the area on the brain where it's coming from. And so another example on the right side here, between FP2 and F8, that electrical difference corresponds to a line on the EEG here, right on the right. And so all these little arrows between these electrodes ultimately come out as lines, and then we get a full representation of how different areas of the brain are communicating with each other. So why did my child's doctor order an EEG? So most commonly, and probably why you guys are here, is EEG is very important in the diagnosis and monitoring of epilepsy, which is a disorder of recurrent unprovoked seizures. And so sometimes if a child has only had one seizure ever, Having an abnormal EEG showing findings that indicate the child is at risk for having more seizures may be enough to actually make the diagnosis of epilepsy, even if the child has only had one seizure. And having one seizure with an abnormal EEG may prompt your doctor to want to start anti-seizure medications. And then in a child who has a known diagnosis of epilepsy, particularly if seizures are difficult to control with medications, EEG can provide us information about where the seizures are arising from, what they look like, how we identify them, and can help guide us in terms of our management of seizures if we need to move on from medications to surgeries. It gives us a lot of information. And then the other thing is it can also provide us information as neurologists about and families how well controlled the seizures are. Because sometimes seizures can be very hard to detect clinically, and we can only see them sometimes on an EEG. And so having that proof of the electrical activity can tell us in someone who has very subtle clinical seizures can prove and verify that when we think they're seizure free, they really are, or are they still having, very small subtle seizures. And then outside of epilepsy, EEGs are still very commonly ordered whenever children have any sort of abnormal behavior or spells they think may be relative to seizure or an underlying process in the brain. Similarly, we also will use EEGs typically in intensive care unit settings to monitor brain function after injury, because as I said, an EEG is really a direct measurement in real time of how the brain cells are functioning and the electrical signals they're producing. And so that gives us a lot of real-time information about how the system is working. So I'm sure many of you may have already had your child have an EEG, or if you are going to be referred for one, just to give an outline of what the EEG procedure entails. So this is an example. It's basically they will stick wires on your child's head, and then like I showed earlier, then we will interpret them. So usually it is done by an EEG technologist, and they're specially trained to know where to put the stickers on the head and how to connect it to our EEG device. The head, depending on how long the EEG will last, sometimes a more durable dressing or bandages is put on the heads around the leads to prevent the child from scratching at them or pulling them off, particularly if the EEG is going to be lasting more than a few hours or even days. And then during the study, the technologist, and I know if you listen to Dr. Rismanchi's talk, she mentioned a little bit about this. They will do some additional tests usually so that we can see the brain's response to things. And those typically involve hyperventilation, which is blowing really hard and fast. Typically, we'll use a pinwheel because that can incentivize the child to blow. And we expect to see a typical response from that. And the other thing that is sometimes done in these EEGs is photic stimulation, or the use of strobe lights, or using bright lights at several frequencies to see how the brain responds. The setup on average is about 30 minutes or so. It depends a little bit with the cooperativity of the child. And then I will tell you a little bit about the different times of recording depending on the EEG. And then the electrode removal maybe takes about 15 minutes. And sometimes you may be stuck with a little bit of glue in your head, but it eventually washes out. Sometimes coconut oil can be very helpful. But all in all, it's a non-invasive study. There's no radiation. And even though we're talking about electricity and wires, there's no shock to your child. We're not stimulating anything. We're just recording. So it shouldn't be painful. It just may be scary. And if the child isn't prepped and kind of knows what they're doing, it can be a little bit scary. So there are several different types of EEGs that your doctor may order depending on what the reason is for obtaining the study. So that's just a picture of what an EEG machine looks like. That's what the actual wires are plugged into, and then it puts out the data on the computer. The most common EEG that's ordered is a routine EEG. This is usually the standard, easy to order, typically is about 30 minutes of recording. And then, like I said, it's probably about 30 minutes of setup and 15 minutes of takedown. And often, but not always, the doctor may request that you keep your child up late the night before the EEG. And the reason is for that is, as I'll go into in a minute, we like to see data from the child awake, drowsy, and sleep. And so if they're sleep deprived, it increases their likelihood that in the 30 minutes of recording, they'll fall asleep. And that's important data for us to have to assess their brain function and their risk for epilepsy. Typically, these EEGs don't include video because it's a brief recording. Sometimes they do. But usually in the routine EEGs, the standard protocol is they will also, depending on the age of the child and ability to cooperate, do the hyperventilation and possibly the photic stimulation with strobe light. Another type of EEG that's a little bit more complex, may last longer than a routine EEG, is a video EEG. And this is the same setup essentially as the routine EEG, but it can be a couple hours or even several days in the hospital where we're recording the brainwave activity as well as video recording as what your child is actually doing that corresponds to the changes in electrical activity. Usually when these video EEGs are arranged, the goal is to capture spells of interest or seizures to definitively confirm that something is a seizure and causes a change in the brainwave activity. And particularly if we know someone has seizures that are very difficult to control with medications, we will bring them to the hospital to provoke seizures to see what they look like from start to end on the EEG, where they come from, to help us guide to see if there may be other options for that child, such as surgical options. And then another option that we're seeing more these days, more recently, is an ambulatory EEG, which is a study that can be 24 or more hours of recording. The child comes to the EEG lab, gets hooked up to the electrodes, plugged into a little portable machine that can be in like a backpack, and then they go home and wear the study for 24 or several days of recording to get measure the brainwave activity while the child is in their home environment. And that can be very helpful because they don't have to stay overnight in the hospital. Sometimes we can use video in those. It's a little bit challenging because the video has to follow the child wherever they're going. So oftentimes it means keeping the child in a room where we can have the video. Sometimes they don't have video depending on the machine. And in that case, we will ask the parents to keep a diary of what their child is doing while they're hooked up to the EEG to see if they have any unusual spell of interest that the family is worried could be a seizure. We will look at the diary when we correspond it to our interpretation of the EEG to see what was happening in the brainwave activity in that moment. And so as far as who reads the EEGs, so many general child neurologists can read EEG studies. And so a general child neurologist is someone who has completed a residency in child neurology, which is 5 years after medical school. And you're learning in part of your neurology training how to read and interpret basics of EEGs. So many of the routine EEGs can be read by general child neurologists. Sometimes adult neurologists also will read routine EEGs. But when it comes to the studies that are a little bit more advanced or more involved, those are usually read by child or adult neurologists with additional training. Fellowship training in clinical neurophysiology and or epilepsy. And so I am an epileptologist. I've done residency in child neurology and then did an additional year of epilepsy training and clinical neurophysiology. And so people who have that additional training can interpret complicated EEG studies, ones that have associated videos, sometimes ones that even go deep into the brain, intracranial EEGs, which is outside the scope of this talk, because we're focusing on sort of the newly diagnosed and how to interpret your first EEGs. But that's kind of a sense of who interprets the study. And it's important to know that the individual who is reading and reporting the EEG may not be, and probably isn't, your child's primary neurologist. and therefore may not be familiar with your child's clinical history. Sometimes they're given a one-liner about the age of the patient, but more than likely don't know very much. And so it's always important to interpret the results of the EEG in the context of your child's particular case, which is why your primary neurologist is the one who will be best to talk to you about the results and to interpret them and tell you what that means for your child. So when I am reporting EEGs, and when most of us are reporting when we learn to read them, there's sort of a structure that we follow when we write these, and I'm going to go through some of that. But so if you ever are confronted with the actual paper report, you'll understand a little bit about the terminology and what it means. And so usually at the beginning of the EEG report, there will be a summary about the technique, the machine that was used, what types of activation procedures such as hyperventilation or the photic stimulation were done, age of the child, a brief clinical story. And then when we actually go into the results section of the report, we always first talk about the background. And so that is just looking overall at the electrical activity, seeing what state the child is in. Are they awake for the study? Do they become drowsy? Do they fall asleep? And when we're trained in epilepsy, we know that there are expected patterns of what we should see as far as frequencies of electrical activity, voltages, organization, different frequencies we should see in specific areas, and how that changes with age. And so we look for expected age-appropriate patterns, and we'll comment on that, whether it's normal, if it's abnormal, why it might be abnormal. Then we'll go into a section where we comment on activation procedures. And so this would be the response to the strobe lights or the hyperventilation. And with both of these things, when done, there is an expected normal pattern of response that we see in kind of the normal brain, depending on the age, if they're able to participate in these things. And then there are also certain things that are red flags to us, particular responses that may indicate, well, this is something that we can see in very specific epilepsies. And I'll go through that a little bit. I think Dr. Rizmanchi talked about some of that in her talk, but we'll report on that in the EEG. Then there may be a section that discusses interictal activity, which by definition is abnormal because it's implying that there's risk for seizure, and this is the between seizure activity. And so when this is reported that there were interictal discharges or interictal abnormalities, that is an abnormality. And so when we report that, we describe, were there abnormalities that suggest an increased risk for seizures? And if so, where were they seen? And then finally, we will have a section that will talk about ictal activity, which is, were there seizures during the study? Often in a 30-minute routine EEG study, we don't often see seizures unless they're happening so frequently that our likelihood of capturing them in just 30 minutes is high. Sometimes we can see absent seizures in a 30-minute EEG, particularly when we provoke them with hyperventilation. But you'll always see something in the EEG report saying, were there seizures or were there not seizures? And so that's just important to see. And so that's just a picture of the pinwheel that your child will probably be given if they're old enough to cooperate to do the activation procedure of hyperventilation, where they'll typically ask them to do it for about 2.5 to 3 minutes. So now I will go through some common EEG findings. Just a caveat, this is not a very extensive lecture. I can't expect you guys to become neurophysiologists after this, but at least to have a pictorial representation of what some of these things look like if you see them or see them described on your child's EEG, and what they mean and what the limitations are in interpreting these. So the most common EEG that we see is the normal EEG. It's very common. And I'll show you kind of a picture of what it looks like. It does vary by ages as far as what is normal, what's acceptable. The caveat with this is that even in children who have epilepsy, they may have a normal EEG between seizures. And that, I think, for some families can be very frustrating because you get a study that's normal, but you know your child and them having seizures is very not normal. But understanding what EEGs can do, it really is a real-time recording of what your child's brain is doing in that moment. And if they're not having a seizure, sometimes abnormalities can be so subtle between seizures that they can't be picked up from EEG that's on the scalp. Because if you even think about that, the electrodes are still, even though they're on the scalp, quite far away from certain deeper parts of the brain where abnormalities may be present, but we can't record them and we can't detect them on a scalp EEG. The other thing is sometimes children who are on anti-seizure medications get an EEG. Those seizure medications can mask abnormalities and can cause EEG changes and normalize an EEG even if the child still has epilepsy. And if that child were to stop the seizure medications, their EEG may become abnormal and they may have seizures. And so that's something to always consider. If you're given a result of a normal EEG, it doesn't necessarily mean that your child no longer has epilepsy, but it may be a reflection of how the medication is helping them and the effects it's having on the brain electricity. So this is just a screenshot of a normal EEG. And if you remember a little bit some of the schematic that I showed you at the beginning, just sort of looking up here, you can start here. This is the left side because of the odd numbers. Right side, left side, right side, and then the F is frontal, kind of central, and then this is the posterior region. And so this is a normal EEG, and in a normal EEG, we expect it to look a little bit bland. Overall, the voltages are sort of low. We see this posterior activity that is a waking rhythm that we expect to see. We expect to see a certain level of organization, continuity of the lines, no interruptions by high voltage activity that would be abnormal. And sometimes your eye might be drawn to some of these things right here, which are actually eye blinks. So that's artifact. So that's the movement your eye makes when they blink. And if you actually see where that location is, it's right here at the front of your head. So those electrodes are picking up movement artifacts. So it's not actually an abnormal brain wave. So this is just a screenshot of a normal EEG in a older, like adolescent. Baby EEGs in general, the frequencies are slower and higher voltage in the younger children, but just to get a schematic of an example. And like I said, an EEG is 30 minutes of recording. And so each one of these we would be scrolling through about 30 minutes of that in a routine EEG. So another common abnormality that we can see and often report on is called generalized slowing, which is a non-specific finding and can't give you a diagnosis per se, but it is commonly reported. Basically what that means is that we see slower frequencies of activity than expected for age in all regions of the brain, or that is to say in every line on the EEG. And this is suggestive of a global brain dysfunction or problem, but it doesn't specify the cause and it also doesn't specify the reversibility. So a common cause, for example, in children who are in an ICU on many medications is the medication effect itself is causing slowing of the brain waves. And that doesn't necessarily mean there's a irreversible problem, it's just an effect of the medication. Sometimes we can see diffuse slowing in the setting of an infection, metabolic disturbance, for example, low oxygen, or some genetic conditions, structural problems that deal with basically all the cells of the brain can present abnormalities in their electrical firing, resulting in slower frequency activity. And I'll show you in a picture what that looks like in a minute. And like I said, it may be reversible. It depends on the cause. And the EEG report may put something along these lines that, oh, generalized slowing is a non-specific finding, may be related to any one of these things. But unless the clinical situation of the child, it's hard to interpret what that means, especially for the neurologist who's reading the study and doesn't know your child. To make an interpretation sometimes can be hard. And so here on the left, there's just a repeat picture of what a normal EEG looks like. You see the variety of frequencies, organization, symmetry. And then this is an example of a very abnormal EEG, diffuse slowing. And so you see these waveforms here that are slower. They're about 1 per second, and they're seen on the left side, right side of the brain. In every lead, you're not seeing this more expected, faster, normal activity. You're just seeing these very slow waves. And so that's an example of what diffuse slowing means. And there can be very large degrees of this and how significant it is. This, I gave a pretty dramatic example, but sometimes it may just be mild and the frequencies are mildly slow for age. Sometimes we can see that in the setting of children who have learning disabilities, developmental delays, and we know that their brain isn't quite working optimally. Sometimes we will see slowing and we think that that makes sense in the clinical picture, but it may not be as severe as this example I'm showing you. Another finding we can see is focal slowing, which in contrast to slower frequencies that we see in multiple regions or in all regions at the same time, this is typically in one or multiple but very specific areas. Again, a non-specific finding that indicates a regional brain disturbance. Common causes of this, usually the thing we worry most about is a structural problem. So is there a tumor? Was there a stroke? A developmental abnormality that is basically impeding normal electrical signals, resulting in slowing over that area when detected on a scalp EEG. And we also can see focal slowing after a focal seizure, which I'll show you in a minute. But in a child who has an EEG right after they had a seizure, or if they have such frequent seizures that between seizures, that brain area never kind of fully recovers because it's just slow and then has lots of seizures again, we can see focal slowing. And if found, we take it pretty seriously. And if a neurologist hasn't already gotten some sort of imaging, like an MRI, when we see focal slowing or focal abnormalities, that will usually prompt us to get neuroimaging to make sure that there's no tumor or structural lesion there that's explaining that finding. And so here, I'll just give you a minute if you want to look at that and see if maybe you can find the abnormality. But here again, I'll orient you. This is the left side because the odd numbers left here. This is sort of the middle that kind of directly above the head here. And then this is the right side, the frontal, and then here's the more posterior. But when I'm looking at this, I see what looks abnormal here. Well, look at these slower frequencies here that are present just in this area, but not in the same region, but on the other side. That's an example of asymmetry and something that right around here when we see T8, F8, P8. So this is an area of focal slowing. And so if I try to figure out, well, what does that mean? Where is that in the head? Going back to our model here would correspond to the right parietal and temporal region here on the scalp EEG. And then when you put it on the brain, you're like, the problem is right here in the right temporal area. And so this is an example of someone who had a tumor in that area. But there can be a number of causes for that, but that's how we draw conclusions when we see these studies and what they might mean. So now I'll go into epileptiform discharges. This is another common thing that might be reported on in your report and can have pretty important implications for your child, especially if the child has only had one seizure and they have an EEG demonstrating epileptiform discharges. That may actually mean that they meet criteria for epilepsy and your neurologist may want to start medication. So epileptiform discharges are areas of abnormal signaling that indicate sites of brain irritability that have risk for generating seizures. They can be focal, as in just one or several very specific areas, similar to focal slowing. This is a focal abnormality, or they can be generalized and seen in every area of the brain at the same time. And these include things that are called sharp waves, spikes, polyspike wave discharges. That's the terminology that you may see, and that as epileptologists, we report on based on certain shapes, morphologies we see. And the important thing with these discharges is that they interrupt the background. And so if you remember back to that first normal EEG I showed you with sort of lines that are continuous, when you see a shape like this, and I've drawn these myself to give you a schematic, but this is a sharp wave. This is something that just interrupts the background, stands out, and is an abnormal discharge. And so that's a little bit what sharp waves look like. Spikes are like sharp waves, but they're a little bit skinnier. So that is, they last a little bit shorter. And then spike waves are abnormal. You'll have a spike followed by this slow wave. This is kind of what you'll see. And in a polyspike wave is you'll have a few of these spikes followed by a slow wave. And when these are described in the report, so we will talk about them as far as what their voltage is, how tall they are. We'll talk about how frequent they are. Are they frequent? Are they rare? Are they occasional? Do they only occur in sleep? And sometimes if we see a lot of them, we'll talk about the frequency that they're seen. So for example, they occur in bursts of 3 spikes per second. And that is terminology that is put in the report. So like I said, you can have focal and generalized epileptiform discharges that can be any combination of the sharp waves, spike waves. And so this is an example here. Hopefully you can obviously spot it. It's this high voltage interruption of the background. And this is generalized spike with some poly spikes. So a couple of them followed by slow wave. And these are not seizures, but they indicate that this individual is at a risk for having generalized seizures. And here's an example of focal epileptiform discharges that are just in specific areas. So if here's an example, and you can think to yourself where they might be, but you look for, are there any interruptions in the background up here? No, not really, but you get down to here to the right. Now we're in the temporal and occipital or temporal area really. And we see these sharp waves and spikes that interrupt the background, and they're in these regions, and those happen to be the right central and temporal areas of the brain. And so these are focal sharp waves in the right central temporal regions. And this is actually from a patient who has benign Rolandic epilepsy that Dr. Rismanchi mentioned a little bit about, or we call it BEX, benign epilepsy with centrotemporal spikes and sharp waves. I'll just comment briefly on this. I don't have a great example to show you, but sometimes on the report, someone will comment that there's diffuse excessive fast activity or prominent high frequency activity. And this is most commonly, if we know a reason for it, it's seen in patients who are on certain anti-seizure medications, benzodiazepine or barbiturates, for example, phenobarbital. Common examples will be an EEG that is obtained shortly after a child had a seizure, but they got a rescue medication such as Ativan or Versed. It will cause excessive fast activity that we'll see. Or if the child is taking a medication called Onfi, that classically will cause excessive fast activity. And I just mention it because it's commented on, but it's really does not have any clear significance, and it's not harmful. It's just an effect we see on the EEG. So if you see that and then you're wondering why, it may be that it's because your child is on one of those medications. And then in some cases, we just don't really know why. And so now I'll go into just a little bit about what seizures actually look like on the EEG. Like I said, usually when we do routine 30-minute EEGs, we don't expect to get seizures, except in the case when we're suspecting absence epilepsy and we do hyperventilation and parents come in saying that their child has very frequent staring spells where they zone out. So this is what an absence seizure looks like on an EEG. And so when this happens, we'll have the child blowing on the pinwheel. And if you look here, we see this is generalized because it's in every line. And we see spike wave discharges in every line. So generalized spike wave discharges that are occurring about 3 times per second. And this whole thing is about 9 seconds. And usually when we see things like this was taken from a book, but presumably when we see this, usually the child is blowing on the pinwheel. And when this seizure happens, they stop blowing, zone out, do the typical staring spell. And then as soon as this is over, they return back to themselves and resume blowing. And so this is a generalized 3 hertz spike wave absence seizure that lasts about 9 seconds. Typically, we don't, on a routine EEG, expect to get other types of generalized seizures, such as generalized tonic-clonic seizures. But to give you a sense of what those look like, if your child, for example, has been admitted to the epilepsy monitoring unit and we're trying to provoke seizures and we want to see what they look like on EEG, this is an example of a generalized tonic-clonic seizure, which starts all of a sudden right here. And it's honestly even difficult to see. We can use special tools to minimize the voltage, but usually in a very violent convulsive seizure, there's so much muscle artifact that we can't even make out a lot about the waveforms unless we do special things on our data to tune out the noise and look at it. But this is sort of what happens, and I just wanted to show you how abrupt the onset is and how it happens in every lead at the same time. And so that's an example of a generalized tonic-clonic seizure. Focal seizures, I'll show you an example. This, again, we may see them in a 30-minute study if they're brief, but typically we're looking for these when we have the child admitted to the hospital for several days on EEG to better localize their seizures. And so this is an EEG, and to orient you, this is the left side. These are the odd numbers, front to back, front, back. And this is the right side. And if you try to see where is the abnormality, where do things start to change, and you look here, it's in the left side. The left O1 is the lead in common here, where this rhythmic, fast, higher voltage activity starts. And that corresponds to the child's seizure, which this is one of my patients, which was a seizure of looking eyes to the right side and not responding. And then ultimately, I'll show you in a second. So this is focal seizure that arises from the left occipital region. And then shortly after, you can see some focal seizures do actually spread to the other side. And so you can have something that starts as a focal seizure and then spreads. And by the time it's on both sides, at that point, you may be seeing a generalized convulsion. So in summary, I went through quite a bit of information and I hope it wasn't too technical. And please, if you have questions, I would welcome them. EEG is an important non-invasive tool for neurologists to help diagnose and monitor epilepsy, among other conditions. The most important thing is epilepsy is always a clinical diagnosis, and the EEG we use as a tool to help us better treat children with epilepsy, and many children with epilepsy can have normal EEGs. Similarly, many children who have epilepsy and we feel they have an epilepsy syndrome that they've outgrown and they haven't had seizures in a long time, they may persistently have abnormal EEGs showing discharges that says they're at risk for having epilepsy, but it doesn't 100% mean that they will have seizures. And that's why all of this needs to be interpreted with your neurologist. Because your neurologists treat your child, not just the EEG study. And so it's always important to take in the context of your child's clinical story and the individual situation for the family. And so now I'm a little bit early, but if I have any questions from anyone, I'm happy to answer any.
Yes, we do have some. I'm going to quickly answer the last question that just came in. Is this recorded so someone can go back and watch? Yes, all of the Expo videos will be and presentations will be recorded, but give Sophie's Journey some time to edit or however they're going to parse that out and give them some time to post it. It will be on their epilepsyawarenessday.org website, and they will be posting on social media when that is ready. It's estimated in a few weeks, but give them some grace because they've worked their tails off to bring this to us. But yes, that will be available for viewing later because this was great information. I have typed in some questions myself. Okay, so into questions for you, Dr. Skora. What type of scenario will an ambulatory EEG be best?
Yeah, great question. So ambulatory EEGs, sometimes we run into this problem where children have episodes that sound maybe concerning, that they could be seizures. And then we may bring them into the hospital, and then for whatever reason, the hospital is not the home environment and they don't have the episodes of concern. And, if the parent says, well, my kid only has these episodes when he's working on his homework or when he's at home playing, sometimes having the child in the home environment with the leads to actually perform the episode of interest, whether it be a seizure or any other, tics, other movement disorders, we can see that it can, being in that home setting can be helpful to provoke the event of interest. So that's one reason we'll do it. Some families find it just more convenient. They don't want to be staying in the hospital. And I know now, even with the COVID pandemic, that's been a consideration. Families don't want to spend, all that time in the hospital. It just means they come, get hooked up, can go home and then get unhooked. There are risks and benefits to it. I will say they're a little bit harder. If we really wanted a detailed evaluation of seizures, it's helpful to have them in the epilepsy monitoring unit where they're on video and technologists can troubleshoot any electrical issues 24/7. But we also find we can get helpful information from the ambulatory EEGs if we just, for example, want a seizure count, to confirm someone who has absence seizures and is treated on medications, and parents say, yeah, we think they are not having any seizures anymore. Sometimes having 24 hours of recording to just confirm that, and you don't need the video to see it because you can just see, did they have any seizures on EEG in 24 hours? Then they don't have to stay in the hospital for that. And so that's a common reason we'll also do it.
Excellent. All right. Again, if you guys have questions, please put them in the chat section. I typed in some questions, so I will ask those now. With focal slowing, does that doesn't go away between the frequent focal seizures? Does that go away or reduce after like seizure reduction or seizure freedom, or is there continual slowing?
Yeah, that's a great question, and it has to do more. So slowing can be like a result of a seizure, or it can be if there's a structural problem there that is causing the seizure and also causing the slowing. So for example, if it's from a tumor or a developmental dysplasia, even if the slowing or even if the seizures have stopped or on good control with medication, you might still see the slowing, and that's because that structural thing is still there. But in many cases, they're focal epilepsy and we don't see anything structurally. It doesn't mean that there isn't a very tiny abnormality there, but it's too small to detect on EEG. And if the slowing is a direct result of frequent seizures, yes, when we stop the seizures, when they're under better control, often we'll see that the slowing goes away.
Excellent. Kind of piggyback on that, what does the focal slowing look like in a child's behaviors and abilities?
So that I wouldn't say there's really anything it would look like. It's more just it's an indication for us as neurologists to see, oh, there looks like there might be a little problem there. It's more the generalized slowing that sometimes we can see, not necessarily, causing behavior changes, but overall kind of just if we know that there's a global process and they're not acting right, and we may see slowing, and that makes sense to us. But I don't know if, focal slowing, you can really think about how it might be reflected in behavior. It's more of something we just see on EEG from a structural problem.
Excellent. If someone is seizure free, but they have an EEG and you do see spikes and waves on an EEG, does that inform treatment decisions?
Yeah, absolutely. So that's actually, it's a really tough question, because we find it very often. Sometimes, a child will be seizure free on medications for many, many years, and we keep getting EEGs, and maybe it will show like one discharge, it may not show very many of them, or maybe it does show a lot of them. And that comes down to a really honest discussion with the family about risks and benefits of continuing medication versus trying to come off and see what happens. Like I said, those discharges do indicate an increased risk to have seizures, but it doesn't mean that you necessarily will. I would say that, when making decisions about coming off medications, I think the desire to drive is a very important thing in my mind. And so I'm much less inclined to recommend someone come off medication, even if they've been several years seizure free, if I'm seeing a lot of discharges, just because my worry that if they were to have a seizure while driving, that's so dangerous for them and for those around them. But I think, we often are, especially in some of the epilepsies that we know that children tend to grow out of and they stop having seizures, we can still see abnormalities on the EEG, and sometimes we'll still say, well, they've still been seizure free for a long time. Let's see how they do off medication. And a lot of it is trial and error. But it's, I'm less willing to do trial and error when children are at the driving age, that critical window when you don't want to really be experimenting with whether or not they're going to have a seizure if you try something.
Okay, those were my questions. Does anybody else have any questions? Please utilize that chat section. Yay. Okay, somebody popped one in. Question regarding photosensitive epilepsy. I've seen research papers where blue sunglasses work for some, whereas others need cross-polarized glasses, I'm guessing. In other cases, blue sunglasses don't work. What do you have, any information on that?
Yeah, so I know, so photosensitive epilepsy is actually quite rare. I know that, there's a lot of, I think, hype about it, that like the bright lights cause seizures, but it's actually in a very rare subset of patients that truly have photosensitive epilepsy. And I don't know specifically about blue glasses, but I do know sunglasses do help those individuals that, and so I think just blocking the bright light, it does help, but I don't know kind of more specifics about what types of sunglasses and things like that.
Okay, and then do you know if that is tested by them wearing the glasses during an EEG?
Yeah, that's a good question. I can't say that I've ever had someone desire to do that, but it could easily be tested if you have the glasses and you want to see, if it still provokes the same abnormalities or seizures while wearing them. We just haven't done it.
Excellent. Okay. Any other questions for Dr. Skora? No? Oh wait, is LGS only shown through spike and wave?
Is LGS, so LGS, Lennox-Gastaut syndrome. So that, the definition for Lennox-Gastaut syndrome is part clinical and part what we see on EEG. So usually it's, we expect to see multiple seizure types and certain classic seizure types, such as tonic seizures or atypical absence seizures, drop seizures, plus some degree of developmental regression, intellectual disability. And then the third thing comes to the EEG finding, which is seeing slow spike and wave discharges on EEG. And so those, I didn't get into too much detail on that, but it's spike wave discharges occurring at a frequency of between 0.5 and 2.5 hertz. So a half time to 2.5 times per second is called slow spike and wave discharges. So it is part of the strict definition for LGS, but I will say sometimes we don't always see that, and we use other clinical factors when making that diagnosis of LGS, but that is one of the characteristic strict definition parts of it, is to have slow spike and wave discharges on EEG.
Excellent. All right, any other questions for Dr. Skora? Utilize that chat section. We still have minutes, and I'm sure she'd be willing to
absolutely
chat with you guys. Okay. I'm not seeing any more. Do you have anything else you'd like to add, Dr. Skora?
Generally? No, I think one thing I did put a little thing up here for Epilepsy Awareness Day next year. Little plug, it's going to be the 8th, 9th, and 10th, and hopefully it will be live and we can all see you guys in person at Disneyland and enjoy the park and meeting everyone in person. And it's a great opportunity for families to meet others and network. I was there last year in person, and so hope to see you there.
Yes, we will be there as well. We missed Disneyland this year. So let's, fingers crossed that things are safe and good to do that. If you don't mind, I would love to share, again, if I have minutes, I will brag about my organization all day. So again, you may have seen us in previous years. If you did go to this expo in person, we always have the big purple sparkly table, and we're kind of the little welcoming committee. And we miss you guys so much in person. We do offer an event that will be virtual that is coming up on Friday, November 13th, and it's called Talk to the Doc. And so we will have a panel of our local Orange County doctors. Unfortunately, Dr. Skora is down in San Diego, but maybe next time we will have you there. We would love to have you, Dr. Skora, at any of our events because San Diego is not very far from us at all. And we have a lot of members in San Diego, so you're always welcome to join us. But we will have about 18 doctors from the Orange County area coming and having a panel discussion virtually. And then we will have breakout rooms where you will have the opportunity to chat with each doctor, talking to the doc. That's hence the name. So I'm gonna go quickly for those of you who may not have seen, our website is right there. I'm going to go ahead and put it in the chat section so you guys can check that out and receive more information. Every single month we have a program night where we have a talk kind of similar to what you just experienced. And so we would love to have you guys, and we're here to hold your hand through every step of the way, IEPs to getting referrals to just a bad day and everything in between. So I will have that information there for you. I can't type and text at the same time. Not a skill I've acquired yet. There we go. And if you have any questions, we also have a phone number that we are accessible at, and we would love to chat with you. I'm so glad I was able to meet you, Dr. Skora. You answered some questions I've had about EEGs for a long time. I haven't gone to a talk specifically about EEGs in a few years, so it was nice to get those questions answered. I appreciate that a lot. And an earlier comment also complimented your